It's time now to talk about the future. I think that the future happens to already be here. It's just unevenly distributed, as has been said by other speakers. And so possibly what you'll hear about today is some of us who are moving in that direction. Maybe we're jumping off the diving board head first into cement. I'm not sure, but that's where we're going. So let's start by putting a little context into how fast the market is changing. And I want to think about it economically as well as socially and within the context of sort of where it's going to take our healthcare profession. So if you think about our market, just in what has happened in healthcare, in the delivery system in the last 6 to 8 months, there has been huge movement in the healthcare market, both nationally and locally. So we all know that the Supreme Court upheld the Affordable Care Act. We know that the Medicare Shared Savings programs were launched, which have increased the proliferation of ACOs both nationally and here in North Carolina. And in addition, we've had remarkable consolidation of the market in ways that we haven't particularly seen before, not only among providers and payers, but other parts of the industry that are starting to mix it up and change in different ways and come together in different ways. When you see an industry that is in the middle of consolidation like we've been having, it's in the middle of consolidation because it's at a point of decline. And part of what we have going on right now is an industry where, as we mentioned earlier today, 52 million Americans are without health insurance. There was a study done 10 years ago that said, when will the fee-for-service system start disintegrating? And the answer was when we reach 50 million Americans without health insurance. So there's nothing surprising about the consolidation that we're seeing. It's just simply part of what's going to be happening in our industry. And the real issue for us is what are we going to do about it and how we're going to lead that. To summarize what the Supreme Court said, it said that the individual mandate was unconstitutional, but it said that that was okay because it was really insurance. But it also, of course, said that the expansion of Medicaid is constitutional, but you wouldn't necessarily have to do it at the state level, and it did not threaten your current Medicaid assistance. So that left the industry presuming that we would probably be going forward, regardless of the election and how that turns out, in some way down the path towards what's being called accountable care. And that in and of itself is also going to basically move the market in ways that we have not particularly anticipated as to the speed that it will do. So you're going to continue to see a shift to retail and consumerism. The public exchanges are set to open in 2014. The private exchanges are already here and taking root. And employers are looking to basically change the way that they're providing health care insurance to something that's far more of a contribution model. This is already having an impact on physician revenues and hospital revenues as consumers and patients are really starting to take and think about the way that they're getting care in much different ways. There will be a continued migration, whether you like it or not, to value-based models. CMS has been thinking about things like the accountable care organizations for at least 12 years through both Republican and Democratic administrations. And it's because our current fee-for-service system really has quite a problem with unsustainability. And so there's been models that have been thought through, and it's going to continue on as a result of all the things that we know. There will be a continued transformation of the healthcare industry into an information business. A lot of what you'll hear me talk about at the end, depending on the time, is how our organization of physicians sees this as being crucial. And a lot of the business models are going to be about information enablement and getting the right information not only to the patients, but to physicians and those that are providing care so we can do it in a more cost-effective, high-quality way. Right now in the United States, already 10% of all Medicare patients are in an ACO. And if you look at North Carolina, we're not exactly not leading in this area. There are, if you look at both the private and public ACO types of arrangements, which are essentially value-based delivery systems, we have both in this state. So you will see on the eastern coast of the state, Wilmington Healthcare, which has announced something with Blue Cross Blue Shield. We know that Coastal Carolina has a public Medicare Shared Savings Program. Cornerstone in the middle of the state has got both private as well as governmental ACO-type contractual arrangements. And then you have others all over the state. And my understanding from talking to many other folks out there is that in January there's going to be several others that are involved with this across our state. It has interestingly been quite physician-led. If you look at Cornerstone Healthcare, Wilmington Health, Key IPA, Coastal Carolina, with its Atlantic Integrated Health Network, these are institutions and organizations that are not necessarily centered around a hospital. The Triad Health Network, which is part of the Greensboro-Moses Cone ACO collaborative, is really being run and organized by the 800 physicians that are part of that. You could consider what Novant has done through the years as being the very first of the ACOs when they began participating in the physician group practice demonstration project over a decade ago. So our state actually is quite far along compared to many of the other areas of the country. Pay attention to what's happening nationally. We've spent a lot of time today talking about the politics of it, but I think we need to understand a little bit more about the healthcare delivery industry because there's strange bedfellows out there. Healthcare Partners was an independent, California-based multi-specialty medical practice with its own wraparound IPA and insurance product that was just bought by a dialysis company. If you look at what's happening all over the place, you're having insurance companies such as Highmark decide to buy hospitals and then decide not to buy it, and now some other insurance companies looking at Allegheny. You have consolidation in our market of things such as the Carolina system that's just come into an agreement with the Cone Health System. UNC has just announced merger discussions with High Point Regional. So there's many things that have not been local, and there's many things at the national level that are quite different and also a sign of an industry that's changing. The reason is that we're too expensive. We've got wildly variable care with lower than desired quality and outcomes. And so when you have an industry like this, it's right for somebody to invent something that's better. Part of what we think that we're going to do up here today is talk to you about our efforts at that from our own perspective. The big focus is on the concept of value. Yesterday on the way to work, I saw one of those little signs by the street as I was turning into work, and it was for Apple Academy, which was a child daycare. And they were advertising high quality and low cost, okay? Because in the daycare business, that's what you have to do. You have to have somebody, if they're going to leave their child there, think that it's going to be high quality, but you have a lot of folks who can't afford child care and it's going to be low cost. And so it was value, value, value for Apple Academy for daycare. That's been something that in our industry, though, we haven't necessarily understood before because quality was always about doing more and more and more, and it wasn't necessarily about doing the right thing sometimes as it was doing more things. So now that we're talking about value, what we're talking about is really understanding in new ways what high quality and low cost together mean from a consumer standpoint and from all those that are paying the bills. If we don't understand that and we just keep doing what we're doing, which is called insanity if you keep getting the same results, then we are going to be subjected to becoming a commodity because what you will do is that they will just keep looking at it from a price only as opposed to understanding how you can bring quality into the occasion. So those that are actually able to shift from fee-for-service, which will be commoditized, to fee-for-value, which will be about a good price and high quality, are going to be the ones that are going to be successful. And in my opinion, it's going to require physician leadership. So the real thing from a business standpoint, to really get into the details of this, is to think about the way our industry has been organized and where it's going to be in the future. So with reimbursement, of course, and fee-for-service, there were a few little things that would tweak us, like DRGs for the hospitals and some of the regulations on readmits. But the type of reimbursement that we're going to have going forward is going to be on more than that. We've got one revenue source right now. It's called fee-for-service. In a fee-for-value world, there's actually 6 potential sources of revenue, depending on how the contracts are set up. There can be fee for service, as there always was. There can be risk for those who figure out how to do that. There can be gain share for those that figure out how to partner with others. There can be revenue for patient satisfaction. There can be revenue for quality, and there can be revenue for other aspects of management that you can be paid for. So as you understand value-based contracting, you have to understand about the different sources of revenue. The organizational model that we've all grown up in has been departmental. You do as many things as you can, as efficiently as you can, at the level of your particular department or practice, and you take home the rest. And that's what fee-for-service is about. It's about efficiency at the departmental level. Where we're going to is about efficiency at the global level. So you might have to put more money into primary care, even if it's not very cost-effective. You might have to see patients that are the ones that have the highest spend, and do it in a way that you're putting more resources into them to basically save the entire system money. So the organizational model is going to be about conditions, it's going to be about populations, and for many of the specialists, it's going to be about being a focused factory. And by that I mean that you will be the absolute best orthopedic surgeon you can be with the best results, and for the first time it's not going to be about just doing a number, as many as you can, and not getting sued by having a basic level of competency that allows you to bill and please patients, but it's going to be about showing outcomes that you're better than everybody else, or that you're the most efficient prospect out there. The value drivers are going to be quality and low variability and efficiency at the population level. And the profit pools are going to be on keeping people well, on chronic condition management, where most of the cost is, and on population management and understanding how to differentiate the population into the different aspects of where the cost is. So you need to be thinking about acute care, chronic care, preventative care, those patients that never show up in your office, those patients that are going to hit the ER one day that you've never even heard of, because in the system we're going to, you're going to be responsible for them too. And the most important thing that I don't think many of the hospitals and many, quite possibly of the medical groups either quite understand, in our state at least, is that it's not about investing in capacity where we're going. There seems to still be a crane in every parking lot of every hospital in this state, as far as I can tell. And that may be okay within the context of the baby boomers that are going to age and we're going to have to take care of them. But the capacity alone and looking to have more referrals and all of that are still based on a fee-for-service system. Your value-based investments are going to be about information. It's going to be about those types of things that are going to allow you to take care of people in ways that will permit you to have a clinically integrated approach. And it's not necessarily on being the biggest and everybody doing everything all over the place. It's going to be about some people can do this good and some people can do that good, and about investing in how you clinically integrate the very best folks out there and figure out collaborative partnerships. So this is a really different model. But we've got a burning platform. If we don't fix this, we're going to get fixed. And there are not enough physicians, and we're going to be doing it in collaborative partnerships, and we're going to be doing it in team-based care. But I do believe we can do it, and you're going to hear some examples now, this morning, from some other folks that are out there venturing out and doing it. So with that, let's start with Coastal Carolina. Let's hear what you're doing down there at the beach.